Thank you everyone for joining us for this special webinar to discuss the Supreme Court's historic decision upholding the constitutionality of the Affordable Care Act. The decision gives California and the rest of the nation the green light to proceed with the implementation of health care reform. Dr. Gerald Kominski, Director of the UCLA Center for Health Policy Research, joins us now to dissect the decision and take your questions. We really want this to be a conversation. So if you have a question, simply type it in the field at the bottom of the chat window. Let's get right to it. Jerry?
Carla, thank you very much. It's a pleasure for me to be here today to talk about, as you described, this historic decision. So the 2.5 years ago, on March 23rd, 2010, the President signed into law the Affordable Care Act, which I described at that time as the most historic day in the history of healthcare legislation since 1965, when President Johnson signed into law the Medicare and Medicaid bills. Yesterday's decision is obviously another historic date. The court has essentially upheld all of the major provisions of the Affordable Care Act. And so when we look at where do we go from here, the simple answer is that we move forward with implementation of the bill as written, with one major exception, and I'll talk about that. The court did find a provision of the Medicaid expansion to be unconstitutional. And I'll talk about that in my comments, what that means for states. But essentially, as Carla described, we have a green light to move forward with the implementation of the Affordable Care Act. And so what I'd like to do quickly today, before we get to the Q&A, and I really do want to leave sufficient time for questions and answers, because I'm sure that there are a lot of excellent questions out there about issues that will be informative to everybody. But I'd like to quickly review the major provisions of the bill and where we are with regard to implementation, both here in California as well as nationally. Sort of what is the report card regarding progress in implementing this bill. So what's gone into effect? The bill was signed, I mentioned, March 23rd, 2010, and there were a number of provisions that were required to go into effect within 6 months of implementation, of enactment of the legislation. So starting in September of 2010, there were certain provisions that went into effect that affect all current and new health insurance policies. The provision that most people are familiar with is extended coverage for children up to age 26. Parents can now keep their adult children on their health insurance policies as long as they have a group or a family policy. Children no longer have to be financially dependent on their parents. In other words, they don't have to be in college. They don't have to be unemployed. They can be employed. They don't even have to be living at home. The only exemption or exception is that adult children who are eligible for their own employment-based insurance are not eligible to stay on their parents' policies. Current estimates are that there are about over 3 million young adults who are currently benefiting from this provision of the Affordable Care Act. Some of the other provisions that went into effect 2 years ago, insurance companies can no longer cancel policies without good cause, a process that's known as rescission. The bill has eliminated lifetime dollar limits on benefits, and the estimates are that slightly over 100 million Americans have benefited from this change in insurance laws. Insurers can no longer put a lifetime dollar cap on benefits. The bill's eliminated pre-existing condition exclusions for children under age 19, and it eliminated restrictive annual dollar limits on benefits. So these provisions all went into effect just about 2 years ago. At that time, there were also provisions that were implemented that apply only to new health insurance policies issued on or after September 23rd. And again, one of the most widely known is the provision to provide coverage for appropriate preventive services at no out-of-pocket cost to the insured member. And appropriate preventive services are defined as those that are graded with an A or B by the United States Preventive Services Task Force. This body reviews the literature regarding the effectiveness of preventive services and assigns a letter grade based on the quality of the evidence regarding the effectiveness of those preventive services. And then a couple of the other provisions are listed here, that pediatricians and OBGYNs can be primary care providers, and ER use can be, you can use the ER without pre-authorization. So what are we doing now moving forward? Moving forward, as I think most everybody in this webinar knows, that the major provisions of the bill really start in 2014. And that's with the establishment of the exchanges and the expansion of Medicaid. As part of the creation of the health insurance exchanges, starting in 2014, insurers will have to sell standard health policies, which are known as qualified health policies. The qualified health policies have to have the same essential benefit package, and the process of defining what's in the essential benefit package has been delegated to the states. There's language here on the slide that's actually from the law itself that designates what the Secretary's responsibility in defining the scope of essential benefits. But the Secretary and the administration has basically given states the leeway to define the specific services that are going to be included. And that will be a state decision. So that's an important element of the implementation of the Affordable Care Act that needs to move forward, both in not only in California, but throughout the country. Within the exchanges, there are going to be 4 tiers of these qualified policies. This is known as the Olympic medal series, bronze, silver, gold, and platinum plans. And just to remind everybody, these plans don't differ in their benefits. The benefits are the essential health benefits. What differs, these plans differ only in the amount of out-of-pocket spending or out-of-pocket requirements for individuals. So the bronze plan is the most affordable plan because the premium is expected to cover 60% of the cost, whereas 40% of the total benefit cost will come from out-of-pocket co-payments and deductibles. The platinum plan, on the other hand, will have a higher premium, and the premium is expected to cover 90% of total spending, whereas out-of-pocket spending would cover the other 10%. Catastrophic policies are going to be available to make health insurance more affordable to young adults who don't qualify to remain on their parents' plans, but these policies will only be available to young adults up to age 30. All of the qualified policies that are going to be sold in the exchange and outside the exchange are also going to have annual limits on out-of-pocket spending. You can see that the limits are fairly low, about $6,000 for individuals and about $11,000 for families. There'll be lower limits for individuals between 133 and 250% of poverty. But this is an important benefit that most individuals don't experience today. Most of us, our insurance policies do not cap our annual spending. So this is an important benefit of the Affordable Care Act that's going to have broad implications for people buying insurance both in the exchange and outside the exchange. Policies are going to have to comply with guaranteed issue and renewal requirements, and all policies will have to eliminate lifetime and annual dollar limits on benefits. So again, just reviewing what is going to occur with the exchanges, the states have to move forward with establishing their exchanges, and California has already made significant progress in this area. States are required to establish an individual exchange and a small group market exchange for companies with 100 or fewer employees. Within the exchanges, only qualified health policies with essential health benefits can be sold. So in other words, those policies that I just described. And those policies, insurers will have to sell them both inside and outside the exchange. So I think one point of ongoing confusion about health policies and health benefits starting in 2014 is that the exchange will be selling one type of policy, but people will be able to buy different policies outside the exchange. And that's just not the case. It's going to be these standard health policies according to the 4 tiers, and those policies will be sold both in the exchange and outside the exchange. Insurers will have to set their premiums for all new policies using what's known as modified community rating. And what that means is that insurers can only charge different premiums based on age, tobacco use, family size, and geographic location. Health status will no longer be allowed as a basis for setting premiums. The law retains existing small group and individual insurance markets, both in and outside the exchange. But for insurers that sell policies outside the exchange, the premiums have to be set based on the combined membership in and outside the exchange. So what this means practically is that if an insurer is selling a bronze plan in the exchange and outside the exchange, the premium for that bronze plan for that company has to be exactly the same in both markets. You can't charge a lower price outside the exchange as a way of trying to encourage perhaps a different mix of patients to buy those or individuals to buy those policies outside the exchange. So this is what is moving forward with regard to changes in the insurance market. Now let's just review what the mandates and the penalties and the subsidies available starting in 2014, because this is really what where all the attention was focused with regard to the Supreme Court case. The bill does impose penalties for being uninsured of up to $695 per adult starting in 2016, up to a maximum of $2,085 per family, or 2.5% of household income, whichever is greater. This maximum or this family penalty is capped to be no greater than the national average cost of a bronze plan, which obviously is to be determined. But the point is that there's not unlimited liability here. No one will have to pay a penalty more than the cost of the bronze plan. The heart of the Affordable Care Act is that it provides subsidies based on the cost of the silver plan for people with incomes below 139 and 400% of the federal poverty level. And at the bottom of the slide, just to remind people, because I know that it's difficult to carry around what today's federal poverty level is, and the fact is it varies depending on family size. But in 2012, I've got examples of what the federal poverty level is in this year for a family of 4. The law establishes limits on out-of-pocket spending for premiums that range from 3% to 9% of income, 9.5% of income for people in this 139 to 400% bracket. And it's a sliding fee. So at the low end, if you are at 139% of poverty, you pay about 3% of your income. for the premium, and the subsidy from the federal government makes up the difference in the cost of your plan. There are some individuals below 139% of poverty who will qualify for exchange subsidies because they're not eligible in their state for Medicaid, and those individuals would pay 2% of their income as the premium, with the government subsidizing the remainder. The law expands Medicaid coverage to anyone with an income below 139% of FPL. And this was one of the provisions yesterday that the Supreme Court found unconstitutional, because the law, as written, required states to expand eligibility up to this level, and basically the penalty for a state that was not in compliance with this expansion would be entire defunding of their Medicaid program. So the court found that this was unnecessarily coercive and unconstitutional, but it's not clear what is going to happen as a result of yesterday's decision. If a state decides not to expand, now that it's not required, there's an expectation that some states may not want to expand up to this level. And it's not clear what's going to happen to individuals who fall below this, the 139% federal poverty level, in a state that chooses not to expand its Medicaid program. But we can talk more about this in the Q&A. Other provisions of the law that are already in effect. The Medicare Part D donut hole is going to be closed on a gradual basis between now and the end of the decade. We've already begun making progress in that area. We've eliminated cost sharing for Medicare preventive services. We've established small business tax credits for firms with fewer than 25 full-time employees and less than an average wage is less than $50,000. The next provision here on the slide, the medical loss ratio, is actually something that's going to be getting a lot of press. It's begun to get press, and I predict over the next 2 months is going to get more, because the first rebate checks are starting to flow. The insurers are required in the individual or small group market to pay out at least 80 cents for every dollar they collect in premiums. And in the large group market, insurers are required to pay out at least 85 cents for every dollar they collect as premiums. Insurers had to file recently their financial reports demonstrating whether they're in compliance with these medical loss ratio minimal thresholds, and insurers that are not in compliance will be issuing rebate checks to their either individual members or to the employers who purchased insurance on behalf of their workers. And those rebates are due August 1st. So this is actually a provision of the bill that the estimate right now is that there will be approximately $2 billion in rebates nationwide. And then finally, another provision of the bill that's already in effect is premium rate review at the state level. And the bill has provided subsidies to the states to increase their capacity for reviewing insurance rate increase requests. Just quickly, I wanted to show you a map of the latest progress as of May 2012 reported by the Commonwealth Fund. State progress in moving forward with establishing health insurance exchanges. And I think the point that I want to emphasize here is that we know that there were 26 states that brought the lawsuit challenging the constitutionality of the ACA. Many of those states, if you look at this map, have made little or no progress in establishing exchanges because they've taken the position that the law was unconstitutional. Now that it's been found, its constitutionality has been upheld, there's a lot of of ground to make up in the next 12 months or so for states that have not moved forward with this important part of the implementation of the law. But you can see that California is, on this map, one of the blue states, and has made, although it's certainly not indicated on the map, California's made significant progress in the last 18 months in getting its exchange up and running in anticipation of enrolling over 2 million newly eligible individuals starting late in 2013. So with all of that as background and sort of just in summary, I think the Supreme Court's decision yesterday was a pleasant surprise. As I was describing to someone just recently, the politics of this case led many people to believe over the last few months that the law might be found completely unconstitutional, or at a minimum that the individual mandate would be found unconstitutional. I think what's interesting is that a number of legal scholars and a number of prominent healthcare leaders and people who work in the industry for months have been saying that their advisors have been saying that the law would clearly be constitutional. So I think that this is an excellent example of how the political environment in which we live today, which is highly polarized, is not necessarily reflective of the underlying sort of trends or doesn't accurately reflect certainly what the court was taking into consideration or necessarily reflecting what popular opinion is regarding this important piece of legislation. So I'm going to stop there with my sort of formal comments and move to the Q&A.
Thanks very much, Jerry. We have a lot of questions, and we'll try to get to as many of them as we can and take them in the order that they came in if we can do that. I'm going to summarize Gerald's question. She wants to know how many states might not sign up for the Medicaid expansion and what the real impact of that might be.
So my initial reaction is that there were 26 states that brought the lawsuit regarding the questioning the constitutionality of the law. Those are likely candidates not to move forward with Medicaid expansion. But I will say that governors that choose that course of action do so at their own risk. It's one thing to join in a lawsuit challenging the constitutionality and being part of a larger political process that says that we are challenging the authority of the federal government to implement this law. Now that the court has found the law constitutional, governors in states that choose not to participate in the Medicaid expansion will have a different group that they need to be accountable to, and that will be not only the voters of their state, but the hospitals, the doctors, and other healthcare providers that will see billions of dollars of lost revenue because of a principled political stance that their governor is willing to take. So I think that there's a significant risk now on the part of governors that want to continue to pursue a opposition to participating or complying with the requirements of the law. But I expect that there are at least 3 or 4 governors positioning themselves for a run for the presidency in 2016 who might be willing to take that risk.
Another question, Jerry, wondering what the pros and cons of offering plans both inside and outside the exchanges.
Well, I think that inside the exchange, the clear advantage or incentive for insurance companies is that there are going to be millions of new customers with subsidies to buy private insurance. And I think that that's really has always been at sort of the heart of this approach to reform, which is that it is a very sort of middle-of-the-road approach. It attempts to build on existing markets and to try and correct some of the, or fill in some of the gaps in our current patchwork of healthcare financing. So it's bolstering largely the private market, as well as expanding, of course, the Medicaid program. I think insurers have a clear incentive to participate in the exchanges in order to get these subsidized customers. Outside the exchange, I think that there's still a significant market. There's still a lot of people who won't qualify for subsidies. These are higher income individuals, obviously, above 400% of poverty. That's for a family of four. That's a income of about this year about $94,000, and so these are individuals who can afford to buy private insurance on their own if they're not getting it through their place of employment. And I think insurers will still have a strong incentive to participate in that market as well.
Another question, Jerry. What about the uninsured who don't qualify for subsidies?
That's a good question. The bill never has always excluded the undocumented from receiving subsidies or from purchasing insurance with their own money in the exchange. So for individuals who are undocumented and who cannot afford insurance on their own, they will continue to seek care from public clinics, from doctors and hospitals that provide uncompensated care. And the law has provided an expansion of subsidies for federally qualified health centers that are largely responsible for providing care to the uninsured. I think that they'll continue to be an important source of care for people who don't qualify for subsidies.
Mary just wants to confirm that companies will not be able to charge more if someone is obese.
There's no provision in the law for allowing companies to charge based on any measure of obesity.
And another question, what is it considered a grandfathered plan?
A grandfathered plan is a plan that was in existence the day that the bill was signed, March 23rd, 2010. Insurers need to apply to the government to be qualified as a grandfathered plan. And grandfathered plans are exempt from many of the requirements that I reviewed earlier in the webinar. This basically allows the provision that if insurers or employers want to continue offering a health insurance plan that was in existence on March 23rd, 2010, they have the option to apply to the government to continue to offer that insurance policy.
Jerry, a question, how will medical coverage work now for workers' compensation cases?
Workers' comp remains continues as a separate system. It's not, there's no provision in the law for folding in workers' comp. And workers' comp is a state-based system, so there's a lot of variation across the country in the way that workers' comp is organized and financed, but there is essentially no impact on workers' comp from this law.
How will state laws around access be impacted?
I'm not sure I know how to answer that question because I'm not sure what specific laws are being referred to. So I'm a little lost on how to answer that one.
Another question, Jerry. Do you believe the penalty is high enough to encourage people not to opt out?
Well, My initial reaction when I saw the level of the penalties was that they seemed low, and I wondered how strong an impact they would have. But since that initial reaction, I've been involved in research here at the center that I've helped to lead, and this is work that we've done collaboratively with colleagues at the UC Berkeley Labor Center. And we've developed a microsimulation model to estimate the impacts of insurance take-up here in California as a result of the Affordable Care Act. And what we found in the simulation model that we've built is that the penalties, even though they struck me initially as low, nevertheless do have a significant impact on, at least in our model, on take-up rates. So we've run a lot of alternative scenarios over the last 18 months, including we modeled the potential impact of the Supreme Court's eliminating the individual mandate, and found that the penalties actually would have quite a big impact. If the Supreme Court had ruled the individual mandate unconstitutional, we estimated that as many as 1 million fewer Californians would sign up for insurance because they would no longer have to pay a penalty.
Another listener wants to know, why not decouple health insurance from employment and put everyone in individual policies?
Well, there are a lot of alternative reform proposals, and I think that one of the challenges that we faced as a nation is that we've been looking to achieve universal or nearly universal access to health insurance in the U.S. for over 100 years. And for a variety of reasons, we can never arrive at a solution that is satisfactory to all of the stakeholders. And so what happens is we have, largely as a historical artifact, an employment-based insurance system that grew out of World War II and has become the method by which at least the majority of Americans currently have health insurance, and it's taken on its own sort of history. Is it the best way? Do we have is our system of healthcare financing the best way of organizing things? I think we're far from that. But as the Supreme Court challenge illustrates, I think, extremely clearly, that any effort to compromise, to expand insurance, no matter how moderate, is subject to intense political debate, political division, and political attack. And this has been the history in our country for over 100 years. So ideally, I think there are better ways of financing healthcare in the United States than the Affordable Care Act. But the world in which we actually live puts severe constraints on our ability to enact the ideal system.
Jerry, what are your thoughts about employers potentially dropping coverage?
Well, that's an interesting question that's come up since the beginning, since this law was first being considered and then immediately after it was enacted. And my response is that employers always have the option of saving money by dropping their health insurance coverage if they offer it. There's nothing stopping employers prior to this law from dropping their health insurance coverage. The reason that companies provide insurance is that they've experienced over the years that it's an effective mechanism for recruiting and maintaining good workers. And larger firms offer more generous benefits because they compete on their benefit package as well as on salaries. So I think that the fact that this law is in place and will have a requirement for large employers, there is a mandate on large employers with more than 50 employees to offer health insurance or pay a penalty starting in 2014. The fact that that mandate's now going to be in effect doesn't change the underlying dynamics and economics of the labor market. Large companies that drop health insurance benefits risk losing their current workforce, and they risk being less competitive in the labor market.
Gary, Diana would like you to explain what a donut hole is.
Oh, the donut hole. It's too bad that I can't pull up a slide. I have a great slide that illustrates it. But the Medicare donut hole for Part D, which is the prescription drug benefit, it's basically that you have insurance coverage for about the first $3,200 of your spending. You pay 25%. Your insurance pays 75%. But then, literally, your insurance stops once you reach that threshold or that donut hole, and it stops for about $3,000 or $3,500 of spending. So you're 100% responsible for your expenses when you reach that limit until you get to about $6,500 of spending, and then the insurance kicks in again, and you have a 5% copayment. So this is really a kind of an onerous form of insurance for people who have high prescription drug spending. And the estimates are there are about 5 million seniors nationally who fall into the donut hole every year. Because when you really have a lot of spending, your insurance goes away, and this is just kind of a flaw in the benefit design that's being corrected by the Affordable Care Act.
Dr. K wants to know if we really can provide coverage for 2 million people.
For 2 million people? I'm not sure. Can we provide coverage for 2 million people? I'm not sure what that number...
I think 2 million more is perhaps what he meant.
In the health insurance, I'm not sure what the 2 million refers to, but let's assume that it refers to the number that I said in the insurance exchange in California. Can we afford to provide that? The financing of the Affordable Care Act was based on a combination of reduced spending and increased taxes. It is true that nationally the federal government is still has a huge deficit, which provides an enormous challenge to fill. But the spending on the Affordable Care Act is part of that overall federal budget. I think in a sense we're talking about two related but separate issues. At the federal level, the economy needs to start growing at a more robust rate, which will help close the budget gap. But the original financing and the current financing for the Affordable Care Act is largely self-funded.
Another question, Jerry. Will alternative or complementary care be covered?
I don't think I can answer that. It's not part of the essential benefit package, but that because states are given leeway in defining those benefit packages, it's possible that some states may broaden their scope of benefits to include those services. But the answer is right now we don't know, and it's not required.
Patrick wants to know if, oops, I just lost Patrick's question here. Let me go to another one. Do we have a good list of California's essential benefits package related to prevention?
Well, preventive services need to be included, and remember the law requires that anything that the Preventive Services Task Force grades as an A or B not only must be included, but must be included with no cost sharing. So I don't know what the complete list of those services is off the top of my head, but anyone could go to the U.S. Preventive Services Task Force website and literally look up that list.
Bill says ACA provides for more access and utilization of care. The real challenge is better outcome. Can you comment on this view?
I agree. I think that we want our healthcare system. There are a lot of demands and a lot of expectations of healthcare. This law was intended to address one issue primarily, which is the fact that 1 out of 6 Americans in recent years goes without health insurance. So the primary thrust of the bill is to expand access to care. We need to continue to work to make our healthcare system more effective and more efficient, and there are provisions in the bill to support those efforts, but we need to continue to work to make our system produce the best outcomes possible.
ACA provides for more access and utilization of care. The real challenge is better outcome. Oh, we just did that one. Sorry, Jerry. Okay.
Yes. Mm-hmm.
Let's move up here. You said that states could potentially lose lots of funds from the federal government by not participating in the Medicaid expansion. But don't states risk losing a lot of money because they only get the matching funds for the newly eligible, not all the currently eligible who come out for enrollment? Isn't there a financial disincentive?
A financial disincentive. So the current Medicaid eligibles who are not enrolled, to the extent that they now come and seek enrollment in the Medicaid program in their state, it is true that the matching formula for those who are eligible under current law versus those who will be newly eligible, that those are different matching rates. Is that a disincentive? It does mean that states will get less federal matching dollars. It certainly is true. The Medicaid match for newly eligible is 100% for the first 3 years, and by 2020 it will go to 90% federal, 10% state. Whereas for somebody who is eligible under current law, but not signed up, who then goes and seeks to sign up for Medicaid, in California that would be a 50-50 match. So I don't know if it's a disincentive, but it certainly means that states will receive lower federal matching funds, and that will put potentially a little bit of a burden on state budgets.
Do you have an opinion as to how likely the tax penalty could be eliminated via reconciliation given the Byrd rule?
I'm not sure I know the answer to that question. I'm not sure that I can answer that question. But I think I need to skip that question.
Jerry, for LA residents, what do you foresee will be the future of Healthy Way LA? Do you think it will continue to exist? If so, how do you think it will be sustained?
Yeah, Healthy Way LA is a program that's all the counties in California have a version of Healthy Way LA. The program currently allows low-income individuals to enroll in healthcare coverage that's county-based. It's not exactly the same as insurance, but it's because it doesn't allow individuals to go to any doctor or hospital, and it only provides coverage within the county, not in other geographic locations. Will it continue to exist? I think that it will, because Los Angeles, of all the counties in California has one of the largest undocumented populations, but it will be a different program. So if it continues, it will transform into a program serving largely undocumented individuals, which is not what it does today.
Jerry, what about the obesity epidemic in America and its impact on healthcare and healthcare costs?
Well, there's ample evidence that the United States may be losing its leadership in a number of other important categories, but we seem to be leading the world in this unfortunate category. It's a challenge for the entire country, and there are obviously cost consequences, but the health consequences are just as devastating. We need to continue to look for ways to address this very, very serious epidemic that's occurring in our country. And I, as a public health professional, despite the fact that I'm also a health economist, I actually don't think that economic incentives are the primary tool for dealing with this challenge. I really believe that a number of my colleagues in the public health profession have much more effective tools in their toolkit for getting America back in top fitness and leading the world in fitness, not in obesity. We, as economists and as policy analysts, have some tools to contribute, but I think that our tools are a lot less effective than some of the others that are available to other public health professionals.
How will they hold insurers accountable if they do not report with regards to the rebate? What's the penalty for not reporting? I'm not expert enough on the provisions of the regulations that have been issued to know what will happen. How will programs like TB control be effective with the enactment of ACA? I see it as being sort of totally outside the purview, unless there's something that something obvious that I'm overlooking. I think that public health measures are not explicitly addressed in the law. It's not really the focus of the law. So, those efforts continue to be supported through other financing streams, through the Public Health Service, Center for Disease Control, and at the state and local level. Stocks of corporate hospital groups went up after the Supreme Court decision. So do you expect hospital utilization and revenues to go up due to implementation of ACA?
Absolutely. I think the stock market knew exactly, does not pay attention to the rhetoric. They know exactly the consequences of the law. The law is expected to provide insurance through Medicaid expansion and through the exchanges for up to 32 million Americans who are currently uninsured. That translates into more dollars flowing to doctors and hospitals and other healthcare providers. So I think the market correctly responded to the Supreme Court's decision and did so in an immediate fashion.
Jerry, what will the states do in 3 years to make up the Medicaid funding they lose? Sorry, go ahead.
Well, the Medicaid funding that they lose. So I assume that this is referring to the fact that beginning in 2017, the federal match starts to go from 100% down.
When the federal share reduces,
so what can states do? States currently pay for uncompensated care in a lot of different ways, and I would hope that as the need to support uncompensated care programs diminishes, that some of those expenditures can be redirected to support the expansion of the Medicaid expansion. A I don't want to diminish or underestimate the challenges that states face in seeking to find new revenues to support the Medicaid expansion. On the other hand, I do believe that eventually those costs do get borne in the public sector, and that finding a small amount of additional dollars to provide insurance coverage is a much more effective mechanism than waiting until people show up in hospitals and in clinics and paying for care on an uncompensated care basis.
What do you see as the next major hurdles in terms of opposition and implementation?
Well, I don't want to sit here and speculate on what the opponents of the bill are doing today and over the next few weeks. I'm sure that will become clear. I have read that there is going to be a media campaign launched in the swing states to try to capitalize on to capitalize on the decision and mobilize opposition to say, okay, the court didn't overturn this law, but now it's up to us to vote anyone who supported the law out of office so that we can repeal it. So I understand that that's one strategy that will take place, and I'm not going to be surprised when that happens, particularly in the swing states. My concern is with going back to the map that I showed, that a number of states have not made any significant progress in establishing the insurance exchanges. I think our experience in California is that the exchange has been up and running for about 1.5 years. There's a lot of work to do, and I think if you talk to anybody, any of the board members, any of the staff who are working on the exchange, they still have a lot of work to do in the next 12 months, and they've been moving forward at full speed for 18 months already. I'm concerned that states that yesterday learned that the Supreme Court was not going to deliver them from the obligation of moving forward with implementation now face the very real possibility that 18 months from now they'll need to enroll individuals and they won't be ready to do it.
What is the role of health policy research groups like UCLA in realizing the potential upside and effective delivery of care due to ACA implementation?
Well, I think that centers like the Center for Health Policy Research and other groups, both in California and throughout the country, it's really our responsibility and our job is to try and provide as much hard evidence, as much scientific evidence as possible about the effects of, first of all, not being insured, and now we have what is a very exciting challenge, which is to begin to document over the course of the next 5 to 10 years the true impacts of the Affordable Care Act at the state and national level. So I think that we are in a position to work with state, local, and federal government agencies to begin to build the evidence base that shows how is this law really working and how effective has it been in not just increasing access to insurance, but ultimately in improving the health status of Californians and all Americans.
Do the requirements for insurance programs in the exchanges also apply to all insurances after 2014? For example, non-grandfathered employer-based insurance?
They do. Insurance policies have to comply with the requirements if they're not grandfathered. So any new policy that's issued starting in 2014 will have to comply with the requirements that I've outlined.
Justice Roberts' decision that the mandate is a tax leaves some questions. Do you think there will be any policy or political repercussions because of the tax? Will the IRS be able to imprison people who don't pay?
Yeah, that's a great question. So the law, because no one was really focused on the penalty as a tax, well, I won't say no one. I think there were quite a few legal experts who were focused on this issue. But now that the public's attention is focused because of the Supreme Court decision, the law is very clear, and it's very explicit in the original legislation. It says that the IRS is forbidden from investigating or penalizing anyone, pursuing legally anyone who fails to pay this penalty. So just think about that for a minute. This is the only tax that I'm aware of in the federal tax code where Congress has explicitly forbidden the IRS from seeking legal action against somebody who fails to pay the tax. If I fail to pay my income tax, the IRS has every right under law to come after me, and even to to send me to jail. This is the only tax that Congress has explicitly forbidden the IRS from doing that. So I think a number of people have correctly pointed out for some time that this mandate, which is so onerous and has been such, not only was the basis of the one of the core elements of the legal challenge, but also in the politics surrounding the ongoing politics surrounding health reform. The mandate is such a hot button issue, but the penalties associated with this, basically there's a loophole big enough to drive a truck through. If you don't pay the penalty, the IRS cannot pursue you.
A question from Dr. K. There's an access issue in Massachusetts. He says, how will 32 million people find doctors?
Well, I don't think that there's an access issue in Massachusetts. And Massachusetts has dramatically reduced the number of uninsured residents. One of the, I think, misperceptions about the uninsured is that because they don't have insurance, they don't get care today at all. And now that we're going to provide insurance, there's suddenly 32 million people are going to show up at the hospital or at the doctor's office that have never been there before. We're not importing 32 million new people into the system. What we're doing is we're now saying that there are 32 million people who today can't afford to get care, so they wait and then go to the emergency room or go to a doctor or a free clinic. But now they're going to be walking in the door as paying customers. We do know that when people get insurance after they've been uninsured, that they tend to have a certain pent-up demand for care that they've been foregoing, seeking treatment. But that is not a permanent phenomenon. That's sort of a short-term phenomenon. And the fact that we do expect people with insurance to use care on a more regular basis means that there will be an uptick in utilization of services and demand for health care, but we've got a lot of excess capacity in our healthcare system. The last time I looked, average occupancy rates, for example, in hospitals across the country are substantially below 100%. Occupancy rates in California hospitals range on the order of around 70 to 75%. There's a lot of capacity in our system, and I don't think that the 32 million people who are currently getting care, that the increased demand for care that they're going to experience as a result of being insured is going to overwhelm our system.
We are out of time. Jerry, thank you very much, and thank you everyone for joining us. I apologize to those of you whose questions we didn't get to. This webinar will be posted on the School of Public Health's website in a couple days. Our regular lunchtime webinars will resume in September. Thanks again for joining us, and have a good summer.